Assalamu alaikum. Today's lecture, Toxicology and Environmental Toxins. Toxicology, toxicokinetics, absorption, distribution, excretion, and metabolism of toxic substances. Toxicodynamics, the injurious effect of these substances on body function. Other toxicological terms and definitions: hazard, a hazard, ability of a chemical agent to cause injury in a given situation or setting. The conditions of use and exposure are primary considerations, and to assess hazard, one needs to know the inherent toxicity of the substance and the amount to which patients or individuals are liable to be exposed. Risk is defined as the expected frequency of the occurrence of an undesirable effect arising from exposure to a chemical or physical agent. Risk assessment has become an important part of the regulatory process in most countries. So again, these are two terms, hazard and risk. Other terms and definitions: routes of exposure. The route of entry for chemicals into the body differs in different exposure situations. Quantity, duration, and intensity of exposure. Toxic reaction may differ depending on the quantity of exposure, its duration, and the rate at which the exposure takes place. Acute exposure, a single exposure or multiple exposure occur over a brief period. Again, acute exposure that occur over a brief period from second to 1 to 2 days. Chronic exposures over a longer period of time represent chronic exposure. So again, acute exposure and chronic exposure. Special aspects of toxicokinetics: volume of distribution. Large VD means that the drug distributes from the blood to other tissue. In other words, it is distributed all over the body. It is not only in the blood, it is all over the body. So it is not readily accessible. The toxin is not accessible to measures aimed at purifying the blood, such as hemodialysis. On the contrary, or small VD implies that the drug is retained within the blood or extracellular fluid rather than distributing into tissue. So, a drug with a small volume of distribution, I can use hemodialysis. Drugs with large VD include antidepressants, antipsychotics, opioids. Drugs with relatively small VD include salicylates, paracetamol. Again, so a drug with a small volume of distribution means that the drug is mainly in the blood. So, in case of toxicity, we can use hemodialysis. A drug with a large volume of distribution will be distributed all over the tissues of the body, and so hemodialysis will not be able to be used to treat toxicity because the drug is not only in the blood. Clearance is a measure of the volume of plasma that is cleared of drug per unit time. Total clearance for most drugs is mainly the sum of clearances via excretion by the kidneys and metabolism by the liver. So total clearance equal clearance by the kidney, clearance by the liver, and others. But mainly clearance by the kidney and by the liver. In planning a detoxification strategy, it is important to know the contribution of each organ to total clearance. So, for each drug, we need to know, is it mainly metabolized by the liver or excreted by the kidney? Drug overdose can change the usual pharmacokinetic processes and must be considered when applying kinetics to poison patients. Drugs, especially poisons, may injure the epithelial barrier of the GIT and thereby increase absorption. Let's go to the figure. If a drug is given orally, it will be absorbed from the gastrointestinal tract to the liver before reaching the systemic circulation. If the capacity of the liver to metabolize the drug is exceeded, first pass effect will be reduced. So metabolism of the drug in the liver will be reduced. What will happen? More drug will be delivered to the circulation. With dramatic increase in the concentration of the drug in the blood, protein binding capacities may be exceeded. You already know that the drug is either in the free on its own or bound to protein. If the concentration of the drug is increased, protein binding capacity may be exceeded. So, increased fraction of the free drug and greater toxic effect. At normal dosage, most drugs are eliminated at a rate proportional to the plasma concentration. This is called first order kinetics. Let's go to the figure. X-axis, dose of drug, Y-axis, rate of drug metabolism. The more the dose is increased, the more metabolism. This is first order kinetics. If the plasma concentration is very high, as in toxicity, and normal metabolism is saturated, the rate of elimination may become fixed. Here, the blue part, you can see that there is no much increase in rate of elimination. This is zero order kinetics. So again, first order kinetics and zero order when the enzymes are saturated, there is no more metabolism. Special aspects of toxicodynamics. For some drugs, sedative hypnotics, the major toxic effect is a direct extension of the therapeutic action. The therapeutic action is sedation and hypnosis, and then the major toxic effect, is direct extension of the therapeutic action. For many drugs, at least part of the toxic effect may be different from the therapeutic action. Intoxication with drugs that have atropine-like effects. So tricyclic antidepressants, their therapeutic action is to treat depression. However, they also have atropine-like effects. So we have drugs. The major toxic effect is due to direct extension as sedative hypnotics, or is different from the therapeutic action as tricyclic antidepressant. Now, how to manage a poisoned patient? Decontamination should be undertaken simultaneously with initial stabilization, diagnostic assessment, and laboratory evaluation. Decontamination means removing toxins from the skin or GIT. Skin contaminated clothing should be completely removed. Wash contaminated skin with soap and water. What about the GIT? For most ingestions, administration of activated charcoal to bind ingested poisons in the gut before they can be absorbed. We'll talk about it in more detail. Gastric lavage or whole bowel irrigation may also be used in some conditions. Inducing emesis is ineffective and potentially harmful and is no longer recommended. This slide shows the gastric lavage, and as you can see in the figure, the stomach, esophagus, and this is the tube. If the patient is awake, or if the airway is protected by an endotracheal tube, gastric lavage may be performed. Lavage solutions, usually 0.9% saline, should be at body temperature. And the patient should lie like this with performing gastric lavage. Activated charcoal. Owing to its large surface area, activated charcoal can absorb many drugs and toxins. So the drug or toxin will be absorbed to this activated charcoal, and it will not be absorbed and it will not go to the systemic circulation. Does not bind iron, lithium or potassium, and it binds alcohol and cyanide only poorly. It is not useful in poisoning due to corrosive mineral acids and alkali, and repeated doses of oral activated charcoal may enhance systemic elimination of some drugs. This is called gut diarrhea. Cathartics. Administration of a cathartic, other word laxative, agent may hasten removal of toxin from GIT and reduces absorption. Whole bowel irrigation with polyethylene glycol electrolyte solution can enhance gut decontamination. So decontamination with different procedures, but the aim is to remove the toxin from the body. Specific antidotes or antagonists or agents that can treat the poison. So acetylcysteine is antidote for paracetamol, defuroxamine for iron, flumazenil is the antagonist or antidote for benzodiazepines, naloxone is the antidote or antagonist for opioids, physostigmine for antimuscarinic agents, atropine and pralidoxime are used in the treatment of organophosphorus compound poisoning. Oxygen is used in the treatment of carbon monoxide poisoning, and hydroxycobalamin is used in the treatment of cyanide poisoning. Methods of enhancing elimination of poisons. Consider whether measures for enhancing elimination, such as hemodialysis or urinary pH manipulation, can improve the clinical outcome. Hemodialysis is especially useful in drug overdose cases in which the precipitating drug can be removed. Examples have low volume of distribution, and fluid and electrolyte imbalances are present and can be corrected. Example, salicylate intoxication. So hemodialysis can be used for treatment of salicylate intoxication. Forced diuresis and urinary pH manipulation. Renal elimination of few drugs can be enhanced by change of urinary pH. Urinary alkalization is useful in cases of salicylate overdose, and acidification may increase the urine concentration of drugs such as amphetamine. Hemodialysis may be indicated depending on the severity of poisoning or the blood concentration for lithium, salicylate, theophylline, and valproic acid. These are examples. Hemodialysis is ineffective or is not useful in calcium channel blocker, poisoning or toxicity, digoxin, metoprolol, and propranolol, and opioids. Weak acidic drugs are ionized in alkaline medium and non-ionized in acidic medium. Weak basic drugs are ionized in acidic medium and non-ionized in alkaline medium. Remember that ionized drugs do not cross membranes. They cannot be reabsorbed in the kidneys, and so they will be excreted. Basic drug is more rapidly excreted in acid urine. Acidic drug is more rapidly excreted in basic urine. Now, aspirin is a weak acid. In situations of aspirin overdose, then urinary alkalization by sodium bicarbonate. Here, aspirin is a weak acid. In alkaline medium, it will be ionized. It will not be reabsorbed, and it will be excreted in the urine. For amphetamine overdose, urinary acidification by ammonium chloride. Again, why? Amphetamine will be ionized in acidic medium because it is a basic drug. It will be ionized in acidic medium. It will not be reabsorbed, and it will be excreted in the urine. Paracetamol toxicity. One of the drugs most commonly involved in suicide attempts and in accidental poisonings. Acute ingestion of more than 7 grams is considered potentially toxic. This is quite a very high dose. Initially, the patient is asymptomatic, or there are mild symptoms, and these symptoms are GIT symptoms like nausea and vomiting. However, 1 day or 1.5 days evidence of liver injury appears with elevated ALT and AST enzymes, liver function enzymes, and hypoprothrombinemia. In severe cases, fulminant liver failure occurs, and there will be metabolic acidosis, hypoglycemia, encephalopathy, and death. Renal failure may also occur. Paracetamol hepatotoxicity, what happens? This is paracetamol, another name is acetaminophen, and it is usually metabolized by conjugation, sulfation, or glucuronidation. In case of toxicity, with the extreme high concentration, the conjugation pathways become saturated. So these pathways become saturated. Now, paracetamol will be metabolized by the CYP or by the P450 mixed function oxidase pathway. So, this will be metabolized to a reactive toxic intermediate. In the presence of glutathione will convert this reactive toxic intermediate to a non-toxic intermediate. However, again with the extreme high dose, tissue stores of glutathione become depleted and this pathway is blocked. So there will be this intermediate will go and will cause liver cell death or hepatic necrosis. So this is how paracetamol can cause hepatotoxicity. The severity of poisoning is determined from a serum paracetamol level. Here, this is hours since ingestion, and this is the concentration of paracetamol. And here, 4 hours, at 4 hours, if the concentration is here, low risk, no treatment required. Here, possible. If it is here, high risk treatment. Again, at 4 hours or at 8 hours, if we measure the concentration of paracetamol and it is here, then no treatment required. If it is at this part, then treat patient. How do we treat the patient? Antidote, acetylcysteine, most effective when started within 8 to 10 hours. What is the mechanism of action of acetylcysteine? Acetylcysteine acts as a glutathione substitute. Remember, we mentioned that when glutathione is depleted, this toxic intermediate will cause liver cell failure. So here acetylcholine will act as a glutathione substitute binding the toxic metabolite. For fulminant hepatic failure, liver transplantation. At the parasympathetic nerve terminal or nerve endings, acetylcholine is released, and acetylcholine will act at muscarinic receptor. Anticholinergic agents can inhibit the effects of acetylcholine at muscarinic receptor. A large number of prescription and non-prescription drugs, as well as a variety of plants and mushroom can inhibit again the effect of acetylcholine at muscarinic receptor. Some drugs used for other purposes like antihistaminics also have anticholinergic effect. All of these drugs can block the action of acetylcholine on muscarinic receptor. Classic anticholinergic antimuscarinic syndrome characterized skin flushed, red, hyperthermia hot, dry mucous membranes, no sweating, dry, blurred vision and cycloplegia, blind, confusion, delirium, met. So, classic anticholinergic syndrome, red, hot, dry, blind, and met. In addition, the patient may present with tachycardia, dilated pupils, in some situation coma, muscle twitching, and urinary retention. Remember, these agents are blocking the parasympathetic nervous system. Treatment of anticholinergic agents poisoning. Treatment is largely supportive. Agitated patients require sedation with benzodiazepines. Benzodiazepines are sedative hypnotics or an antipsychotic like haloperidol. The specific antidote for peripheral and central anticholinergic syndrome is physostigmine. Physostigmine is a cholinesterase inhibitor. It inhibits the enzyme cholinesterase, increasing the level of acetylcholine. Catheterization may be needed to prevent excessive distension of the blood. Remember, there is urinary bladder, so catheterization. So, treatment of anticholinergic agents. There is specific antidotes, physostigmine. Salicylate toxicity. Poisoning causes uncoupling of oxidative phosphorylation and disruption of normal cellular metabolism. So there will be hyperventilation, respiratory alkalosis due to medullary stimulation. Metabolic acidosis follows. There is increased anion gap. Why? Due to accumulation of lactate and excretion of bicarbonate by the kidney to compensate for the respiratory alkalosis. Often mixed respiratory alkalosis and metabolic acidosis. There is also elevated body temperature, vomiting, and in severe poisoning, in severe salicylate poisoning, there is profound metabolic acidosis, seizures, coma, pulmonary edema, and cardiovascular may occur. Treatment of salicylate toxicity, general supportive care, massive aspirin ingestions. Remember, aspirin is acetyl salicylic acid, more than 100 tablets. Then gut decontamination, gastric lavage, activated charcoal, and whole bowel irrigation. Give IV fluid to replace fluid losses caused by vomiting and fever. Give IV sodium bicarbonate to make urine alkaline. Remember, aspirin, weak acidic, will be ionized in alkaline urine, will not be reabsorbed in the kidney, will be excreted in the urine. So give IV sodium bicarbonate, make urine alkaline, increase salicylate excretion. In severe poisoning, hemodialysis to remove the salicylate more quickly and restore acid-base balance. As you can see, there is no specific antidote for aspirin, and it is generally supportive care. Benzodiazepines pharmacological actions. They modulate GABA effects. GABA is an inhibitory neurotransmitter in the CNS by binding to a specific high affinity site at GABA A receptor. This figure shows GABA A receptor. Benzodiazepine bind to a high affinity site at GABA A receptor. This will lead to entrance of chloride inside the cell, hyperpolarization, and inhibition of the central nervous system. It will show clinically as anti-anxiety effects. Sedative means calming the patient. Hypnotic means putting the patient to sleep. And benzodiazepine also have anticonvulsant property. Toxicity of benzodiazepines: there will be drowsiness and coma, respiratory depression, and cardiovascular compromise. Benzodiazepine toxicity can be treated by flumazenil. Flumazenil is a benzodiazepine receptor antagonist. So if a patient presents with benzodiazepine toxicity, treatment will be by given flumazenil. Cholinesterase inhibitor, remember, acetylcholinesterase break down acetylcholine. So cholinesterase inhibitor lead to increase acetylcholine, which has a parasympathomimetic action. Example parathione, organophosphate cholinesterase inhibitor are widely used as insecticides, absorbed by the skin as well by the respiratory and GIT tract. Remember, parasympathomimetic action. Stimulation of muscarinic receptor will lead to meiosis, lacrimation, abdominal cramps, diarrhea, excessive salivation, sweating, urinary frequency, bronchospasm, and increased bronchial secretion. So parasympathomimetic action. In addition, acetylcholine can also stimulate nicotinic receptors. Nicotinic receptors are in the ganglia and are also at the neuromuscular junction. Generalized ganglionic activation, hypertension, and either tachycardia or bradycardia. Increased acetylcholine will lead to stimulation of nicotinic receptors in the neuromuscular junction, muscle twitching and fasciculation. This will lead to weakness and respiratory muscle paralysis. So at the beginning there is muscle weakness and fasciculation, and this can lead to muscle paralysis and respiratory muscle paralysis, which is very serious. CNS effect: agitation, confusion, and seizure. So the clinical picture for the patient who present with cholinesterase inhibitors will have symptoms of and signs of stimulation of muscarinic receptors, stimulation of nicotinic receptors in the ganglia and in the neuromuscular junction, and CNS effects. Treatment of cholinesterase inhibitors toxicity: treatment supportive. Care should be provided. Decontamination. Atropine will block the symptoms and signs due to muscarinic stimulation, because atropine is a muscarinic antagonist. However, atropine will not block the symptoms and signs due to action of acetylcholine on the nicotinic receptor. Pralidoxime cholinesterase regenerator compound. Here, look at the figure. This is the organophosphorus compound, and this is the enzyme. The organophosphorus compound will attach itself to the enzyme. Now the enzyme is inactive. Here, PAM will come, attach itself to the organophosphorus compound, and regenerate the enzyme. Now the enzyme is active. When the enzyme is active, it will break down acetylcholine. PAM, given early enough, may be capable of restoring the cholinesterase activity and is active at both muscarinic and nicotinic sites. So remember, specific antagonists for cholinesterase inhibitors are atropine and pralidoxime. Atropine will block the action of acetylcholine on the muscarinic receptors only. Pralidoxime will regenerate the enzyme. The enzyme will inactivate acetylcholine, so now restore the choline and is restoring the cholinesterase activity, active at both muscarinic and nicotinic sites. Poisoning with carbon monoxide. So what is the mechanism of action? It binds, carbon monoxide binds to hemoglobin, reducing oxygen delivery to tissue. Clinical features: headache, nausea, vomiting, syncope, seizures, and coma. What is the treatment of carbon monoxide poisoning? 100% oxygen and hyperbaric oxygen. This is in special chambers in special centers. Poisoning with cyanide, mechanism of toxicity: binds to cytochrome, blocks cellular oxygen use. Now the clinical features: headache, dizziness, nausea, vomiting, seizures, and coma. Treatment: there are two kits. The first one consists of nitrites. Nitrite will induce methemoglobin, and this will bind cyanide. In addition, the kit consists of thiosulfate. This will convert cyanide to less toxic cyanothionate. Another kit, concentrated hydroxycobalamin. This will convert cyanide into cyanocobalamin. So, toxic metals with frequent environmental or occupational exposure: arsenic, lead, and mercury. Common source of exposure in drinking water: paint, lead in paint and soil, mercury in air and food. Organ system most sensitive: cardiovascular, skin, and others. Here, lead, CNS, blood, cardiovascular, and renal, CNS, and renal. We are going to discuss lead toxicity in more detail. Toxicology of lead. Lead is used in a variety of industrial and commercial products. It is used in batteries and in paint. Usually results from chronic repeated exposure and is rare after a single ingestion. So there is acute toxicity and there is chronic toxicity. Can damage many tissues and organs. Can damage hematopoietic tissue, liver, nervous system, kidneys, GI, and reproductive system. Form of lead entering the body is either inorganic lead or organic. Inorganic lead absorbed mainly via respiratory and GIT. Organic absorbed from skin and respiratory tract and sometimes GIT. Predominantly target the CNS. So organic lead predominantly target the CNS. Acute lead poisoning, acute abdominal colic. So the patient will present with acute abdominal colic and CNS changes. This include acute encephalopathy. Sometimes hemolytic anemia. Mortality rate is high in those with lead encephalopathy. And from it, chelation therapy is mandatory. We'll discuss chelation after a couple of slides. Chronic inorganic lead poisoning, some of the symptoms and signs: headache, confusion, fatigue, peripheral neuropathy, example wrist drop, anorexia, weight loss, and GI symptoms. Tremors in children, growth retardation, neurocognitive deficits and developmental delay, and in older adults also age-related decline in cognitive function. Organic lead poisoning, the incidence or the occurrence of organic lead poisoning has decreased because gasoline is unleaded in many places, readily absorbed through the skin and lungs. Primary signs of intoxication: hallucination, headache, irritability, convulsions, and coma. So again, organic lead poisoning is mainly CNS. Treatment consists of decontamination and seizure control. Mechanism: inhibition of enzymatic function, interference with action of essential cations, calcium, iron, zinc, generative of oxidative stress. So these are substances which will harm the tissue. Changes in gene expression, changes in cell signaling, and disruption of the integrity of membranes in cells and intracellular organisms. So there are many mechanisms for toxicity by lead. Treatment of inorganic lead intoxication. There is inorganic and organic lead intoxication. Termination of exposure, supportive care, anticonvulsant for seizures, corticosteroids for cerebral edema. Fluid and electrolyte balance must be maintained. Adequate urine flow. Chelators, we'll talk about chelators in the last two slides. We can give IdiTEN calcium disodium IV infusion and dimercaprol. Parental chelation is limited to 5 or fewer days, at which time oral treatment with another chelator, Saximar. Endpoint of chelation or for chelation: resolution of symptoms or return of the blood lead concentration to the pre-morbid stage, to the initial stage before toxicity. Chelators prevent or reverse toxic effect of heavy metal on an enzyme or other cellular target, can also accelerate the elimination of the metal from the body. By forming a complex with the heavy metal, so the chelator will form a complex with the heavy metal, the chelating agents render the metal unavailable for toxic interaction. Contain one or more coordinating atoms, usually oxygen, sulfur, or nitrogen. Donate a pair of electrons to cationic metal ion to form a coordinate covalent bond. chelator metal complex formed are excreted by the body. So chelators will form a complex with heavy metal, and the heavy metal will be rendered unavailable for toxic interaction, and the chelator metal complexes are excreted by the body. Capacity of chelating agent is greatest when given very soon after an acute metal exposure. Here are examples of some chelators. Dimercaprol, used in arsenic and mercury toxicity. Saximer, used in lead, arsenic, mercury toxicities. IdiTA in lead toxicity. Penicillamine in copper, lead, mercury toxicities. Unithiol in mercury toxicity, and Xerox in iron toxicity. Thank you very much. If there are any questions, please contact me.